webinar. I think maybe we begin with our the secretary to give us our poll question, so that then we progress from there into our speakers, who we are so eager to listen to. So the poll question is there on your screen, and you can be able to vote on it. I hope you can see it there. I support the mixing of COVID vaccine. Single choice, you choose. It's a single choice question. I think, are we done so that we'll be able to proceed? So thank you so much. I hope that suffices. And you can see the answers there. 38% say yes, and 59% say no. So we will see as we progress into the session. We are going to learn a lot on these matters. Our first speaker is Dr. Stephen Muleshe, and he's a public health expert. Many of you may have interacted with him or at least heard of him. He's a health policy and health planning expert who has worked with very many organizations, both governmental and intergovernmental and non-governmental, both in Kenya and outside the country. He is a medical doctor. He's a public health specialist. And at the moment, he heads the Department of Intergovernmental Relations at the Ministry of Health. So I'm so eager to listen to what Dr. Stephen is going to talk about. So I think you can take over, Dr. Muleshe.
Thank you very much, Dr. Mbeva, and it's a pleasure joining you this evening to make a presentation on the COVID-19 vaccination from a programmatic point of view, because I sit on the task force, but also just to be able to elicit some discussions on the mix and match and the position of the Ministry of Health and the government as a whole in mix and matching of the COVID-19 vaccines. So I'll start off my presentation with an introduction on where we are as a country. Let me just share. Screen. So I hope you're able to see the screen.
Yes, we can see it.
Okay, so I'll briefly just touch on the COVID-19 situation in Kenya, where we have, then I move on to the vaccination program before I delve into the topic of the day, which is mixing and matching of the COVID-19 vaccines. As you're aware, Kenya is amongst the countries that has been affected by the pandemic. And since last year, March, when the first case was reported, the Ministry of Health has been in the forefront in ensuring that there's all efforts that have been put in place to tackle this pandemic. So I decided to just show the trends of the COVID-19 outbreak in Kenya since when the first case was reported we have had about 4 waves. Actually, we are on the 4th wave, and you can see a lot of the cases are actually asymptomatic. Currently, the 4th wave in Kenya is thought to be triggered off by the variant, different variants of the vaccine that have been reported. And I think Dr. Ndiaoko will be able to delve a bit more on the issue of the variants. In terms of the age-sex distribution of the COVID-19 cases in Kenya, we are seeing more males have been affected than females, but particularly this age group of 30 years to 39, and of course followed by the age group of 40 to 49. And we'll see the implication of this also even as we move on to seeing our first approach to the vaccination program in Kenya. The daily number of patients admitted to ICU in Kenya from 1st January 2021, at least up to 17th August data are showing the daily number of COVID-19 patients in ventilators, on ventilators, has actually increased, and especially in this 4th wave. Same to the number of COVID-19 patients on observation in ICU and the ones needing oxygen in ICU. And this trend has also tended to go with the waves, or to increase with the waves that we've had. As of yesterday, a total of 4,739 deaths have been reported, giving a case fatality rate of about 2%. So this graph basically again showing the corresponding deaths with the trends that we've had from the 1st wave to where we are in the 4th wave. Higher deaths, of course, being reported with each wave. In terms of age and sex, again, what we are seeing here is case fatalities amongst the people elderly, more than 60 years of age, have been affected, particularly the male, who have been the greatest casualties in terms of mortality of COVID-19 disease. So when we come to the vaccination, so the Ministry of Health began the COVID-19 vaccination exercise on 5th of March, 2021. Of course, with AstraZeneca from Serum Institute of India. Now we are receiving more vaccines other than AstraZeneca. I'll be able to report on that. Our target is basically to vaccinate 60% of the adult population by June next year. And following a presidential directive, we have a target of 10 million Kenyans by December this year. So this is a huge task ahead for the Ministry of Health in combating this disease. We know we've had very sluggish consignments of the COVID-19, and especially in the developing world, the African countries, where we've not had the benefit to receive, to have a steady supply as our big brothers in Europe and America. We adopted a first approach. We have a deployment plan, which we have since revised to adopt the multiple vaccines that we'll be receiving. The first phase began in March this year when we started the vaccination program and targeted basically the critical target populations of the healthcare workers, security personnel. We also included the teachers and persons above 58 years old. Approximately a population of about 4 million. We are now on to the second phase, still targeting the numbers of the population that was not vaccinated in the first phase. We know that when the vaccine came into the country, there was a bit of hesitancy. And a lot of the healthcare workers, the teachers, the security forces have not been vaccinated yet. So we are onto the second phase, ramping up that number, but also including people above 18 years with comorbidities, those ones above 50 years, and populations in congregate setting like the prisons and the refugees. So we take a population of about 6.2 million people in this phase 2. And then phase 3, we hope that with sufficient supply of vaccine doses, then we'll open access to mass vaccination, targeting anyone above 18 years and above. And the target population here is 20 million. So just comparing Kenya with other countries where we are in terms of the vaccination, we selected a few countries. Currently, this was as of 20th of August 2021, Kenya, we had vaccinated about 2.4 million people. The figure now is at around 2.8, actually, because of the vaccines we've received recently. You can see compared to Mozambique, Uganda, Malawi, and Tanzania, and that we are not badly off in terms of the numbers we are vaccinating. This is just about maybe 2.8% of the population. So you see, with this, with our target of 60% of the population, the task ahead is quite huge, and we hope that the vaccine supplies will be able to be steady for us to achieve those targets. Again, in terms of the total vaccinations, actually that figure is about 2.8 million. The first dose, these are just updated as of today. We are at about 2.8 million, actually not 2.4, with first dose at 2 million for 4379, and the second dose at 807,000. Total doses coming to about 2.8 million. Second dose uptake at around 56%. So adults fully vaccinated about 2.8%, like I'd mentioned earlier. Just a graphical presentation of where we are with the first dose in terms of the categories of the high-risk groups. We've had these others categories in our first and part of the second phase, because when clients come to the facilities, we will not turn them away, really, as much as we have insisted that we are vaccinating healthcare workers, security officers above 80, above 58-year-olds, but we've not turned away people who come, and especially because of the initial hesitancy that was there and the risk of the vaccines expiring and encountering wastage. We just had to vaccinate people who come to the facility. But of course, the focus will still remain on the high-risk groups. So those are the numbers in terms of the healthcare workers, security officers, teachers, and above 58-year-olds. In terms of the first dose uptake and second dose uptake, and the percentages fully vaccinated, which I'd mentioned, I'd indicated earlier on in the graphical presentation. If you look at the people above 58-year-old, and in the graph that I showed on, the mortality is highest amongst the above 60-year-old. So this is an area that we'd like to focus very much, even in this second phase. We want to ramp up the elderly, especially above 58 years old. And we realize we've brought this age group to below, to about 50, because we've also seen quite a number of deaths for people around that age group. But we will only fully vaccinate about 8.9. These are a low number, and it's a cause of worry for us. And so we are putting all strategies in place to ensure that we reach out to this category of Kenyan citizens who can benefit from the vaccination process. Again, if we look at the sex distribution of the persons who have been vaccinated, we are seeing more males have been vaccinated than the females, both for the first and the second dose. Just to touch a bit on the supply chain and the plans we have for the vaccines. So when we started the vaccination, we started with AstraZeneca, donations from the EU and the UK, about 1.1 million, that was in August. And also from the COVAX mechanism, we received about 407,000 doses. We have also received Moderna. We expected 1.7 million doses for Moderna in August, but we only received about 800,000. So the other half will be coming before the end of this month. In September, we're also expecting to receive Pfizer donation from US government, about 1.7 million. And also through the COVAX mechanism, about 270,000 doses. Sinopharm, through the COVAX mechanism, again in September, we hope to receive about 2 million doses, and Johnson & Johnson, which we had anticipated to receive about 390,600, but that has delayed. So this will be receiving this month, and then staggered over the next 4 months at 500,000 every month until December. So the total doses that we've been able to receive about 3.6 million doses. Today, we actually received 458,000 doses of AstraZeneca from Canada. So that brings the number to about 4 million doses that we have already received. We expect a number of about 4.8 million in September, and then the staggering of the other doses, about 500,000 each of the COVAX of Johnson & Johnson up to December. With our projection of vaccinating 10 million Kenyans by December, we hope with the current vaccination supply plans that we have, we will be able to reach out that population, unless otherwise then we have any problems or delays in the supply of the vaccines. Then we will not be able to achieve this, but we are highly confident that we'll be able to achieve that target. Just monitoring how we've been able to do with the supplies. The 2.8 million doses that have been utilized for the first and second doses in Kenya. Weekly consumption at Kenya is currently at about 270,000. We hope to increase this to be able to achieve the targets. Besides AstraZeneca, we received Moderna in the country on 23rd of August, and more vaccines are also expected in the future. Actually, in this coming month of September up to December. So what plans do you have to achieve these targets of 10 million and 26 million Kenyans? So we hope to increase the daily vaccination rates from the currently 40,000 per day to about 80,000 per day in September, and about 150,000 by December this year. And also increase the vaccination sites, currently operating at about 800 sites in the 47 counties. So we would like to increase this to about 3,000 by December and about 8,000 by June 2022. And this will include both the public and the private health facilities. We also plan to conduct outreaches and operate mass vaccination centers. Some of these vaccines that are coming have very short expiry. And so if we continue waiting for clients to come at the facilities, then we run a risk of wastage and expiries. So we plan to reach out and to people through mass vaccination centers. We know Moderna and AstraZeneca, Moderna and Pfizer have stringent storage conditions. So we also have had plans. We have received ultra cold chain freezers that will support the cold chain system for those two vaccines. As a country, also in a planning mode for local manufacture. There's a team in place led by Cambry. Initially, we'll start with a fill and finish plant, which we hope to be completed by March 2022. And I'm glad to report that the government has put in place a budget for this initiative. So when you come to mix and match for COVID-19 vaccines, we know that mixing COVID-19 vaccine is emerging as a good way to get people the protection they need when faced with safety concerns and unpredictable supplies. The best example, like in our case in the country, when we started vaccination with AstraZeneca, there's a time we were expecting more doses, which never came. And so we were forced to extend the period for second dose from 8 weeks to 12 weeks, just to be able to accommodate that. With mix and match, if another vaccine would have been available, would have been able to have given, but later on I'll tell you as a country, our position on the same, but also safety concerns, and especially in Europe, where there were reports of issues of clotting with the AstraZeneca, but also the other vaccines. And so the reason why a lot of studies are now looking at mixing and matching. So most vaccines against SARS-CoV-2 must be given in 2 doses. We know, apart from Johnson & Johnson, which will be must be given in 1 dose, the rest actually 2 doses. But multiple studies now back up the idea that mixing the Oxford AstraZeneca jab and the Pfizer BioNTech vaccine triggers an immune response similar to, or even stronger than 2 doses of either vaccine. And a number of trials that have been conducted. One of this is the CombiVax trial in Spain that has been published in the nature.com in May 2021, showing very promising results that vaccinating people with both the Oxford AstraZeneca and Pfizer BioNTech COVID-19 vaccines produces a potent immune response against SARS-CoV-2. The other issue that this study reported was that because of the safety concern, actually some European countries are already recommending the sum of all people who are given a first dose of the vaccine developed by the University of Oxford, UK, and AstraZeneca in Cambridge, you could get another vaccine for their second dose. So, but these studies are still limited, very limited data, as we will see later on. Another study, again, by a group of scientists led by a gentleman called Sanders, looked at about 340 healthcare workers who had received either 2 doses of Pfizer BioNTech vaccine or an initial shot of Oxford AstraZeneca vaccine followed by a dose of BioNTech vaccine. So both regimens triggered an immune response that included neutralizing antibodies and T cells. Again, very promising results here. Again, a third study by researchers in Saarland University in Germany found that the mixed regimen was better at eliciting an immune response than 2 Oxford AstraZeneca shots. So it was also as good as or better than 2 shots of Pfizer BioNTech. Again, suggesting that mixing and match gives a better immune response than immunization with the same vaccine. Again, in another study, in a UK study called the COV, which analyzed combination of the same 2 vaccines, that is AstraZeneca and Pfizer BioNTech, found that people in the mix and match groups actually experienced higher rates of common vaccine-related side effects, such as fever, than did people who received 2 doses of the same vaccine. And this study is available, and it was published again in the Lancet. So in the Spanish CombiVac trial, mild side effects were common and similar to those seen in standard COVID-19 vaccine regimens. None was actually deemed very severe. So the results from these studies are also giving researchers confidence that combining other COVID-19 vaccines that haven't been tested together might also work. We know there are quite a number of vaccines in the pipeline, and so with these studies on mix and match, promising good immune response, this could also extend to the newer vaccines that are being approved. Of the vaccines, at least 16 of them that have been approved for use in one or more countries, and mix and match studies so far have been very small. So more extensive trials need to be done with long-term monitoring for side effects, which will be actually very important. And by the end of actually June this year, more results had emerged showing actually a similar effect. Yeah, so the trials, the downside of the trial that they have been too small to test how effective combinations of vaccines are at preventing people from developing COVID-19. But as long as you don't have any long-term or any follow-up studies with the efficacy calculations, it's hard to say the level of duration, again, of protection. So there's quite a number of things that are coming up, quite strong evidence that is needed to be able to even convince countries and even WHO, which has not given any direction or guidance or advice on the mix and match which countries can be able to adopt. So in summary, some key points here that actually vaccines prevent severe disease, hospitalization, and deaths. This is a very key message. Of course, you know, we've had people who have been vaccinated, but they will still get infection. So it doesn't mean that when you're vaccinated, you are totally prevented from getting infection. You'll get the infection, but it will prevent you from progressing to severe disease, hospitalization, and deaths. They do not stop transmission. They will still be there. And so more of the need why other protocols, masking, sanitizing, and social distancing will still be emphasized. We've had breakthrough cases reported, a number of hospital admissions now. There are some studies going on to analyze and see the kind of people who are being vaccinated, and we're seeing that who are being admitted, and we are seeing that actually a majority of these admissions are people who have not been vaccinated. And we know for sure, and even from studies and from publications, that the unvaccinated are the main drivers of the current US wave. So as a country, mix and match of vaccine is not yet recommended. We'll await more evidence, more concrete data to be able to guide on the same. So there's no official position on the same. For now, we still maintain same vaccine for first dose and second dose without mix and matching. Of course, the focus for us, based on the targets that we have set, is on having the 60% of adult population in Kenya fully vaccinated. Of course, meaning that you receive 2 doses of the other vaccines that we are receiving in the country, like AstraZeneca, Moderna, Pfizer, Sinovac. And of course, for Johnson & Johnson, you'll be considered fully vaccinated when you have had your first dose. So thank you very much for listening to me. Back to you, moderator.
Thank you so much, Dr. Mleshe. That was an excellent presentation. We will have the questions after the next presentation so that we can just be able to answer them together and for our panelists to answer them together. So you ask your questions in the Q&A section. I can see people already putting questions there. Let's continue to populate that section with questions, or even in the chat. I'll keep looking at it just to make sure that your questions are coming through. I would like to invite our next presenter. is Professor Jaoko Walter of the University of Nairobi. The professor there of microbiology, virology specifically, and he has so many titles. And sometimes when you are given an opportunity to introduce one of the people you really respect and your seniors, you get mixed up and even don't know which right words to use. So, Prof. Jaoko, maybe you just save me and take over so that I don't veer off track.
Okay, thank you very much for giving me this opportunity. I will quickly go through this. It's a COVID-19 vaccine mixing and matching. And the outline would be just a quick situation, and this will be very fast about Kenya, and then the issues of mixing and matching. And then I just end up with one of my pet topic on ethical issues around COVID-19. So if you start at COVID-19 situation in Kenya, you have already seen this. We're in the fourth wave. We started having COVID cases in March last year, but now we're in the fourth wave. So this is the first wave, second wave, third wave, and the fourth wave. And we're actually doing very well. The numbers are coming down. This is with regard to new infection. And the data is quite updated up to yesterday. And then if you look at the deaths, we are not doing that very well. Again, this is the fourth wave, but the deaths are not coming as low as we would have expected it. And this is again data up to yesterday. So I'll not go through this, but the whole idea of this slide is to show you that the majority of the vaccines that we have given so far, it is AstraZeneca. We received from this organization, the COVAX, which is aimed at providing vaccines for resource-limited countries. But we have gotten some of the AstraZeneca vaccine from friendly countries. Now we are getting some doses from Pfizer. We are expecting some from Moderna, Johnson & Johnson, and then even Sinopharma, as you've heard it being said. And these are the targets that have already been mentioned to you. The whole idea of this is that soon we are going to have a number of very different vaccines. And so the issues of mixing and matching becomes important for us to discuss. So what is this mixing and matching? The idea of mixing and matching vaccine is not new. And there are several reasons why people have thought about mixing and matching. So when you mix, it is called heterologous prime boost regimen, where you are giving 2 doses of vaccine, but different vaccine. The first dose is just to prime the immune response. And then the second dose is to boost that little immune response that has been created. When you're using the same vaccines, we talk about that being homologous prime booster. And there are several reasons why people have considered mixing and matching. One is that we are experienced from HIV and Ebola vaccine. Actually, the current Ebola vaccine is 2 different types of vaccine. You give one type and then you boost with another. The HIV vaccine research that is ongoing, the best results are obtained by mixing one type followed by another. Now, what has also made people start thinking about this mixing and matching is the shortage of the AstraZeneca vaccine. You remember the delays of getting the second dose. And people started thinking, okay, if you delay getting the second dose and you have an alternative vaccine, can you boost it? We're using that vaccine. Then the other concern has been the emergence of variants. And people have been wondering, would mixing and matching be better for the emerging virus like the Delta virus? And then finally, one of those issues of mixing and matching came with the side effects when people started seeing blood clots with AstraZeneca and Johnson & Johnson, and they thought, oh, the second dose, maybe we should use a different vaccine. So this has already been mentioned by Dr. Mleshe about the vaccine breakthrough. And this is specifically with the Delta vaccine, that here you can see the people who have been unvaccinated. These are the viral loads of a period of time. And you can see the red line is higher. And these are people who have been vaccinated. And the viral load is significantly lower compared to people who have not been vaccinated against the Delta vaccine. So the Delta virus. So it's to tell you that the vaccines are still working even with the Delta virus in general. So now regarding what is the recommendation about mixing and matching, and you've already heard, it is not recommended. Why? Because we only have few studies. We need more studies, and WHO is actually encouraging more and more studies to be done. The studies that have been done are on very few people. Remember the homologous vaccine trials that resulted in the registration of these vaccines were conducted in thousands and thousands of people, 45,000, 35,000, and so on. So the WHO says that we need actually more studies if we are going to recommend it. Different types of vaccine that we are using, there are three main groups. We have the mRNA vaccine, which is Moderna, Pfizer. We have the vector vaccine, which is AstraZeneca, J&J. And many of the studies showing mixing have been AstraZeneca and Pfizer, AstraZeneca and Moderna, AstraZeneca and Sputnik. They have generally showed better immune responses, that when you mix, you get better immune responses than when you use similar vaccine. It is thought that probably the immune response will be longer and even more stronger when you mix. And the idea behind that is that the vaccines are targeting different parts of what you call the spike protein. The concern has already been mentioned to you that you seem to get more adverse events, but this is more in terms of frequency, but not severity. So the same side effects that you see when you don't mix are the same side effects that you see when you mix, is only that their numbers are slightly more. And this is a famous one. This is the Chancellor of Germany who received a mix, got a prime with the AstraZeneca and then was boosted by Moderna. I just want to end with ethical issues around COVID-19 vaccine. We know one of the problems is the issue of global access to COVID-19 vaccine. The rich countries have stockpiled vaccines up to 5 to 7 times the adult population, whereas developing countries have vaccinated very few people just because of the shortage of vaccine. You've heard that Kenya, for example, we have vaccinated less than 3% of our population. Now, so as a result of that, we have shortages in, sorry about that. As a result of that, we have shortages of the vaccines. So we have people then jumping queues because of connections and because of corruption. And then we've also had talks about mandatory vaccination, which unfortunately the president reversed, because that would be coercion, it would be interfering with people's human rights, human dignity, privacy, and even confidentiality. So the other thing is this, the issues of equality, equity, reality, and liberalization. This cartoon really shows this very, very clearly. Equity is when everybody has the same opportunities. You say every country can buy whatever they want. They're equal because they have the same opportunity to buy. Equity says, if these are people watching a football match, it says that, you are tall enough. You don't need a stool. You can watch the matches. But this guy who was here very short, you can give them the stool. So then all of you can watch the match. And this is what we are aiming for with regard to COVID-19 vaccine. The reality, though, is this, where the rich countries, although they are tall enough, they can watch the match even without any stool. They have all the stools. They're the ones who have stockpiled 5 to 7 times their population of vaccine. And Africa, with the poverty, limited resources, we're almost in a hole. And the world is urging for liberation, whereby you remove the barriers. So everybody, whether you are short or tall, you can be able to watch a football match. And you've heard about removing patencies for the vaccines. And this is what the world is urging, so that everybody can be able to access the vaccine when you have companies making the vaccines, and so you have enough supply. This is a picture of a global picture with regard to the targets. The countries in dark blue are the ones that are going to achieve vaccinating majority of their adults this year, by late this year. The countries in the light blue are the ones that are going to achieve it by mid next year. So although Kenya is aiming to do that by next year, according to this economic intelligence unit, probably we are going to achieve it at the end of next year and not at the mid of next year. And these are countries that at the moment are doing very, very well. United Arab Emirates, Spain, and so on. And you can notice in this graph here, we don't have African countries, but in my opinion, 2 African countries should be here. Seychelles and Morocco are doing fairly well and have already vaccinated about half of the adult population. Now you heard about this. This is what we are talking about, an ethical issue when the president is said to have ordered that the cabinet get the vaccine as a way of boosting compliance and addressing vaccine hesitancy. Now, it's a good idea that people become vaccinated, especially the leaders, so that other people can, get the confidence of the safety of the vaccine. But it becomes a bit of an ethical issue when it is an order rather than voluntary. And this is a famous one where the head of civil service in Kenya said that, by August 23rd, if you're a civil servant and you have not been vaccinated, you are going to face disciplinary action. And the main disciplinary action was that the salary was going to be stopped. I'm going to stop there and just thank you for your attention and just thank the healthcare workers who are taking care of us during this difficult period. Thank you very much. Over to you.
Thank you so much, Prof. And thank you so much, Dr. Muleshe. So this is a very, very nice presentations, as you've heard, top and backed with a lot of research. So maybe we start with the Prof. Is it safe for children below 10 to get a COVID vaccine?
So, okay, so the studies that led to the emergency use authorization of the vaccine, as you know, were conducted in only adults 18 years and above. At the moment, there are some studies that are being completed in the US on Pfizer and Moderna, and it's showing that those vaccines are safe. So they are making applications now for emergency use authorization. So the current vaccine that we're using in this country has not really been tested in children, and so would not advocate for it to be given in children. So far, I think it's only the US that has started vaccinating the older children, children 11 years to 17 years.
Thank you so much, Prof. So the AstraZeneca we know now and Pfizer also have a study commissioned from 2 years and above, and it's in phase 2 of that study. So we'll wait and see how that comes through. So indeed, like Prof says, maybe not at the moment, but studies are going on. Dr. Muleshe, someone asks here, what are the barriers for women receiving the COVID vaccine?
Yeah, okay, so thank you very much for that question. I think like we've seen from the data that we've have presented from our vaccine electronic register, what we call the Chanjo system, actually more males being vaccinated than the females. And maybe one of the reasons that could be associated with these could be access issues. We know that men are more mobile and get out of home. Women, most of the time, are at home taking care of the children. Those could be some of the factors, but we are also seeing that in other places, like the ASAL's issue of the vastness of the areas has affected access for those vaccines. This could also apply not only to women, but also both men and women. There could be other factors that we'll be able to explore. There are quite a number of studies that are going on now to try and establish especially reasons for vaccine hesitancy. I know University of Nairobi was involved in this study together with KEMRI and other organizations. So maybe again, we'll await maybe the outcome of these studies that will be able to inform us more.
Okay, so one of the things that somebody has appreciated the presenters for really appreciating the health workers and wishes that the government will show similar appreciation. Prof, someone is asking here, just wondering what if it's necessary to vaccinate a person who has been infected with COVID-19 virus or who has had an exposure to the same. I mean, appearing to ask that does an infection confer sufficient immunity? Why should we vaccinate them?
Unfortunately, natural infection does, okay, so the thing is this, that when people become naturally infected, they have some level of immunity. There are two problems. We don't know how long that immunity lasts, and we don't know how strong it is. Because we know that there are people who have been infected twice with COVID. And in fact, I know 2 people locally and even in the US where the second infection was actually more severe than the first. So the advice is that everybody, whether you've had COVID infection or not, you should get vaccinated. Now, the interval, people also ask, after how long can you get a vaccine if you've recovered from a natural infection? The interval is varied. The US government actually talks about 2 weeks from the Center for Disease Control. The European talks about 4 weeks. The Kenyan government advice is 6 months. But I believe it's just probably because of the shortage of the vaccine. So I personally believe that 4 weeks after recovery, you can get a vaccine without any problem.
In fact, while you are there, Prof, someone is asking, what happens when the interval between the first and the second dose is longer than 8 weeks? I mean, when they start delaying for shortages and all sorts of reasons, what happens? Don't we have a problem when you give someone the vaccine at 12, say 13 or 14 weeks for dose 2?
The simple answer is that nobody really knows for sure. So what happened? This story of 8 weeks interval came from the Europeans, so from the UK particularly. So what happened? The studies that were conducted, the primary study advised, the manufacturers advised that the interval should be 4 weeks. But the UK, when they were in the middle of very severe COVID spread, the cabinet made a decision that rather than make a few people be fully vaccinated, and many people have not even received the first vaccination, they reanalyzed the data that led to the registration of the vaccine, AstraZeneca vaccine. And they realized that there was some evidence that delaying the vaccination by about 8 weeks would still be as good as the 4 weeks. So they made a pragmatic decision to delay so that more people get the first dose. And they did that. Now, what was interesting is that the delay from 4 to 8 weeks, the immune response were even better than 4 weeks. But the UK managed to get everybody vaccinated after the 8-week interval. So we don't have sufficient data to say what happens in case the delay is more than the 8 weeks. And so it could be that it would be better. We don't know. It could be that it is similar to 8 weeks, but it could also be that it is less than the 8 weeks. Nobody can really tell for sure. I think an opportunity was missed here. For example, in Kenya, because of the delay, there's some people who received it much later than the 8 weeks, because of the difficulty of getting the second dose. It was hard to know who are those people so that we could then be able to follow them up and see whether the immune response that have been generated, despite the delay more than the 8 weeks, is as strong or better than the 8 weeks or the 4 weeks. Now at CAVI, we are following up people who received the vaccine within the 8-week period, and the immune response have persistently been very good. So my belief is that there wouldn't be much difference between 8 weeks and more than 8 weeks, but there is no scientific evidence.
While you're there, Prof, the question about pregnancy, lactating, and the vaccine.
Yeah, so the vaccine, again, it was not tested in pregnant women and lactating women, except in the US. The US have conducted a study using Pfizer in pregnant women. But my advice would be that, as you know, that pregnancy is a risk factor for severe disease. And if some of you who watched Professor Mondi Ogutu on Saturday, talk about the need to vaccinate pregnant women. Now, although we do not have sufficient data, it's one of those conditions that you weigh your risk, your benefits versus risk. And if I was a pregnant woman, I myself, I would get the vaccine because I know that if I get COVID and I'm pregnant, the risk of dying from COVID is much, much higher than if I'm not pregnant. And because studies have shown what they have done, some women who became pregnant they were vaccinated and then they became pregnant, and they did not know that they were pregnant until much later. The children who were born from those women, none have been shown to have any teratogenic effect. There's been no abnormality noted. So if I was a pregnant woman, I would go for the vaccine.
Okay, thank you so much. Now, Dr. Mleshe, is it possible we could be having deaths that are not reported? And why are the deaths appearing to occur more in men than women? Do we have answers to this?
So thank you very much. Of course, we know even the numbers that we are reporting for COVID-19 is there's a cross-section of what is happening on the ground. We could be having more cases. I'm sure many Kenyans have been infected by COVID-19. But because of the testing issues, limitations of testing, not test everyone. So the numbers we are reporting is just a tip of the iceberg. Same to the deaths. I'm sure there are quite a number of deaths that have gone unreported. And the 4,700 is just a small number. I'm sure it's not a very true picture or representation of the mortality that is experienced due to COVID-19 disease.
And someone is asking, I don't know that you're finished, sorry. So first finish.
You had asked about also why we are
males
deaths more in males. There could be many reasons. Again, here we are seeing currently, and especially that the male species, the breadwinner, and so have to get out of their homes to go and look for resources to fend for the family, and therefore maybe higher at risk than even the woman who stays at home. This is debatable, but I'm sure there could be studies also that could be able to inform this this trend why more males are dying.
And someone is asking that, Dr. Mleshe, someone is asking, I see we are receiving so many donations of different types of COVID vaccines. And my question is, how do you confirm the quality and the safety of these vaccines before they are administered to the population? Because we know with the drugs, they are monitored first, quality assurance, and the rest. What about the vaccines, which you receive today and tomorrow they're in the arms of people?
Yeah, so a very important question again. And that's why as a country, we have decided to go through the COVAX mechanism. And actually most of the donations now, initially countries were very quick to plan for bilateral donations where you reach out to a country and you receive the donation. But now through the COVAX mechanism, it's quite a bit strict. Even those donations have to come through the COVAX mechanism where quality is assured. But as a country, we also have our own systems of checking the quality. The Pharmacy and Poisons Board is on top of things, and therefore they ensure that the vaccines that we are receiving are of quality and in terms of efficacy and effectiveness.
And what is the ministry doing to deal with the questions about the mRNA vaccines being a danger to human beings in the longer term? Those fears and
so there's been quite a bit of misinformation, a lot of rumors on the social media on this, and yet we know very well that really we don't have very concrete evidence to support this information about some of the side effects like infertility. But what I know is that quite a number of studies, and even in the US and in the UK, are going on. We know these are new vaccines. We know COVID is a new disease. And so the vaccines have been developed over a very short period of time. There's bound to be quite a lot of reservations on the safety of these vaccines, but I know the scientists are working around the clock to be able to find evidence on some of the severe side effects. On the issue of infertility that I've seen that has been posted, again, we don't have very clear evidence. I know this is one of the issues that also females have been scared to get vaccination because of fertility. I know the issue of males also affecting their fertility has also come up, but all this we've seen on social media with no concrete evidence from scientific studies. And we'll await maybe to hear on the studies that will come up to be able to inform us so that we can direct policy. But Prof, maybe you could be having some information on the same.
Thank you so much. Let me just keep here. The problem is that there's a lot of misinformation in the social media. It's not true at all. I've seen people saying that the mRNA can mix into your DNA and cause a problem, which is not true. The way the vaccines work, and I think as healthcare workers, we need to be very clear on this because we are opinion leaders and we can inform people. The difference between a vaccine and a drug is that the vaccine only comes and stimulates your immune response and it's gone. You don't find it. I cannot look into your blood and find any trace of the vaccine because it just comes, stimulates your immune response and the body destroys it. Compared to the drug, which is the same drug, it's the one that is fighting the disease, fighting the germ. So we are able to measure the drug quantity in your blood. We can be able to assess that. So the vaccine comes for a very short time and it goes. So how it will cause infertility, how it will cause all these things that people are talking about, it doesn't make sense at all. Then the messenger RNA vaccine does not get into the nucleus of a cell. It goes into the cytoplasm, stimulates the body to produce the messengers, which then makes the spike protein, portion of the spike protein on the surface, and then your own immune response recognizes it and then produces antibodies. So it does not get into the nucleus. So there is no way it can integrate with your DNA. So unfortunately, and this is where I feel sad about Africa, the rumors, the misinformation is manufactured in the West, but developing countries are the consumers. If you look at the population of the West, people who have been vaccinated, 80%, 70%, they're very, very high. And they're still continuing to vaccinate. And by the end of this year, they'll have vaccinated 90-something% of the adults. Whereas resource-limited countries like ours, including healthcare workers, are the perpetrators of the rumors. So we are denying our own people the vaccine from rumors that have been manufactured in the West, and they are being vaccinated. So that is a sad thing about the rumors that you see in social media.
Yeah, and while you are there, the question someone is asking here is, how long, do we know how long this immunity of these vaccines lasts, and when can one then be able to stop wearing a mask if they are vaccinated?
Okay, so there are two things. As to how long the immunity will last, we don't know. For you to answer that, you require what you call longitudinal studies, and those are going on now. And that is the same for any vaccine that was ever developed. There is no way you can make a vaccine for a new disease and say it will give you an immunity that will last for whatever period of time. No vaccine has ever been manufactured that way because you have to follow up people to be able to see how long it will last and whether they require immune boosting after a period of time. All the vaccines have been like that, including yellow fever, which used to think that you require a booster 10 years. And then most studies showed that actually you have immunity for life. So that one, we are doing a follow-up. Every country is actually following up people who have been vaccinated just to see how long it lasts. As I mentioned earlier, in CAVI, we are doing that. There we have a study where people who have been vaccinated, we are following. And it is only those longitudinal studies that will be able to tell us how long it lasts. With regard to wearing of mask, once you have a critical mass that will give you what is what would then be what we call herd immunity, where herd immunity is that you have not been vaccinated, but because the number of people who have been vaccinated are sufficient, the virus cannot be transmitted easily, because wherever it goes, it finds somebody who has been vaccinated. Once you have a herd immunity, then you'll stop wearing masks. If you see, if you've been following what is happening in Europe, for example, if you're a football fan, you watch the English Premier League, the stadiums are full and nobody's wearing masks because they have achieved a sufficient number of people vaccinated that now they can talk about herd immunity. Of course, there is a fear or concern that with the emergence of new variants, there would be some that would be able to give you breakthrough infections. But the short answer of it is that once you have sufficient people vaccinated, at a period will come when you really don't need to wear the mask. But we are so far away from that in Kenya, so we have to continue wearing our masks.
And what happens if an infected person gets vaccinated? Are there concerns, and at what period would you advise that they get the vaccine? Because we've seen all things of 3 months, 6 months. These are those infected after the first dose.
You're asking if somebody who is infected gets the vaccine?
Yeah, a person who got infected, should they get the vaccine? And then secondly, what if somebody gets infected after the first dose? So they get the first dose of the vaccine and then they get a breakthrough. So what happens in terms of the second dose and when?
Okay, so that's, and quite a number of people have actually, remember when you get the first dose, about 27% of the people have some sufficient immune response. The figure varies from 27 to 67 of some level of immunity that protects you from getting COVID. But so the majority of people are not fully protected just by getting a first dose. So we have our own, even in our own country, we have a number of people who become infected, including some prominent people after getting the first dose. Now, when can you get the second vaccination? It is the same guidance. So once you become infected after the first dose, once you recover, you then wait for the US government talks of 2 weeks, the European talks of 4 weeks, the Kenyan government talks of 6 months. I strongly believe 4 weeks is sufficient for you to then get the second dose. And a number of people who become infected after getting the first dose, they tend to get milder disease than if they had not even received the first dose.
Thank you so much. I think we've gone way past our time. I want to ask Dr. Mleshe to make some final concluding remarks. And then after that, Prof will make some remarks and we go to the poll question. So Dr. Mleshe, then Prof.
So thank you very much for inviting me to be able to make my presentation. It's always a pleasure to present in such forums because at the same time, you get also to learn from the questions that are being asked. And on behalf of the National COVID-19 Task Force, I would like to assure Kenyans that the Ministry of Health and the government is doing all it can to ensure that Kenyans are protected. You can see our ambitious targets of vaccinating 10 million Kenyans by December this year, and almost half the population, adult population, by June next year. And I'm sure we'll be able to achieve this. We are working with all our partners to be able to ensure that we receive the vaccines. We know we have challenges here and there, but we'll be able to overcome these challenges. The county governments have also been very, very supportive. As you are aware, health is a devolved function. So basically vaccination is taking place at the facilities which are based at the county. We usually have a forum every week on Tuesdays in the afternoon at 2:30. to be able to update the healthcare workers on the COVID-19 vaccination program. I'll be able to share that link shortly on the chat platform, and you're most welcome. And we look forward to, again, meeting with you again in this forum. Thank you very much.
Thank you so much, Dr. Mleshe. Much appreciated. Thank you for creating time and coming to really help us understand these issues. Prof, up to you.
Yeah, thank you again. Thank you for giving me an opportunity, and it has been a nice evening. Just to, again, appreciate the healthcare workers, and the nurses are really key in helping us to fight this COVID. And I just pray that the message would be the same, that a vaccine is saving lives. Vaccination is the way to go. If you want to reopen our economy, if you want to, go back to school for kids easily, if you want to stop the lockdowns and the curfews, the more people are vaccinated, the better. And as has been mentioned by Dr. Mleshe, the government is doing its bit, and it is our responsibility to also do our bit if we want to go back to some sense of normal. Thank you very much.
Someone was asking, I've just seen a question sneaking in now, and it interests me as well. You have comments on the Mu variant? The new variant.
Yeah, the new variants will always come. So the whole idea of variants is that the viruses, when they're multiplying, they make mistakes. And so when the difference, when the spike protein differs a little bit, a portion of the spike protein differs a little bit, you get a new variant. So our concern is only, we have something called variants of concern. Variants will always be there, but it's only when the variant has a possibility of being transmitted more easily or causing more severe disease or escaping detection, not what we call a viral escape in terms of detection. That is when we become concerned. So far, really, all the variants that we have are being taken care of by the vaccine. So nobody's really worried about them, but we need to keep on monitoring them in the event that we get one that will be much more easily transmitted, like the beta variant, or causes much more severe disease, like the Delta virus. But the key thing is that they escape. If they're able to escape the vaccine, then that is a problem. So far, we have no evidence. And I showed you a graph which compared people who have not been vaccinated and people who have been vaccinated and still became infected with the Delta variant. And there's a very, very significant difference. The vaccine protects.
Wow, excellent. There couldn't have been a better way to end it. I'm so grateful to Prof. Giaoko, to Dr. Mleshe. Excellent top presentations and very, very informative information. And thank you all the attendees for making time to go through this very excellent attendance. I'm really honored to have been your moderator today. I think I welcome the Secretariat to guide on the CPDs and to close the session.
Thank you very much. We welcome Rashid to tell us about the CPD points.
Thank you so much, Dr. Agoro and the moderator, and to all the panelists for tonight. So I'll share with you the procedure on how to claim the CPD points, and as it's being shared on the screen, you go to your NCK portal NCK account. That is, you log into the OSP, that is online students portal at nckenya.com. Then you go to courses, click on live events, you enter the secret code. The secret code is the one that is shown. That is small w, capital X, capital H, and capital I. You click on validate and submit. Then you should be able to receive your CPD points. Remember that the code expires on 4th of September 2021. Thank you.
Thank you so much, Rashid. Let us remember the code expires on 4th of September. Another round of applause to Prof. Giaoko and Dr. Mleshe and our moderator, Dr. Umbeva. You have done us proud. Thank you so much, our distinguished guests. You are always our support, and we exist because you join us. A very big welcome to all of us, and really a big thank you. I know that we have very many senior nurses and other healthcare providers that I may not call all their names, but I want to acknowledge our senior nurses from the diaspora. I can see Dr. Mbago, I can see Juliet, and many others. From Kenya, I can see the Deputy Director, Ruth Muhia. I can see the former principal of Nairobi Hospital, Rosa Mutanyi. I can see our very own senior nurse, Abdi Malim, who has been in EACC. And special thanks to Professor Mageto from Zimbabwe. You have always joined us. Thank you so much. Please, we have learned. Let us remember every fortnight, nurse midwife-led webinar at 7:30 is the place to be so that we share experiences and learn. Thank you so much. Until next time when we meet, it's bye-bye from all of us. Thank you.
Thank you. Bye.
Bye.
Bye-bye, and thank you.
Bye and good night.